of all, hello everyone, and thank you for joining us. This is our second REACH webinar, and we're really excited to be here. I wanted to quickly introduce everybody on the call. With us, we have Dr. Jacob Langer from Toronto Sick Kids, who and also in our world is our go-to for many, many things Hirschsprung's related. Jack is a pediatric surgeon. So that's Jack. And then with him is Dr. Rebecca Rentea from Children's Mercy in Kansas City, also a pediatric surgeon. And we are so excited to have you with us, and thank you for making the time to be here. And as well, I've got Nicole, one of our fabulous HD mom / board members, and Raina, our director of communications, and myself. So thank you for joining us today. I know some of you will be watching this later, as you have been great with sending in questions. But first of all, I'm going to kick it over to Dr. Langer, who's going to, with Dr. Rentea, start with some really great information, I believe, about Hirschsprung's and the pull-through surgeries. But Jack, I'll kick it over to you.
So first of all, your little square says Grace Stewart. So you're in case you say something crazy, you don't want any responsibility. Is that the thing?
Grace is my niece next to me, so she's going. See, there she is. Also, our tech person, and pretty much my go-to in life in general. You have met Grace, actually, Dr. Langer, when we were in Houston.
Yeah. Just so everybody knows that it's not the real person. Okay, so I need to share my screen. I think Grace maybe needs to give me that ability.
Permission.
Yeah. Good thing I didn't say anything bad about her.
We're working on it.
So what Dr. Rentea and I are going to do is spend about half an hour or so just going through a presentation on what bad things can happen, or what kind of problems kids with Hirschsprung's can have after their pull-through. And I will start just by going through what the pull-through surgery is, just so everybody's clear, when we talk about these different pull-throughs, what exactly we're talking about. And then we'll talk about some of the things, the problems that kids can have afterwards, and the approach we take to them. And then there should be lots of time at the end for questions.
Perfect. I think you can share away now.
Yeah, there we go. I just have to find it. And then that. Okay. Can everybody see that?
Yes, sure can.
Okay. So just we'll start with the different operations that we do for Hirschsprung's disease. As everybody, I think, knows, Hirschsprung's disease is caused by lack of the ganglion cells, or the nerve cells, in the bottom part of the bowel. And usually it's just this bottom part here, but it can affect a longer part of the colon, or even the entire colon in some patients. And the goal of the pull-through surgery is to remove the abnormal bowel that has no nerve cells and bring the normal bowel down to just above the anus, while preserving the anal canal, which gives us sensation, and also preserving the sphincter muscles, which gives us control over our stools. So that's the basic idea. Now, at the bottom end, there are several different ways we can reconstruct things. The original operation that was described was the Swenson operation, and it's pretty simple. We take the normal bowel with normal nerve cells after removing the abnormal bowel and just basically sew it just above. These are the two sphincter muscles. So this is actually, there's two, but there's actually a circle around the anus. And we try and do that connection, or anastomosis, just above the sphincters. So that's a simple operation. The Soave operation is a bit different, because in the early days of this kind of surgery, people were worried, surgeons were worried, that they might damage the nerves or the blood vessels in the area deep down in the pelvis here. So what Dr. Soave suggested was, let's remove the lining of the rectum at the bottom, but leave the muscle there, so that the surgeon was actually just kind of within the tube of the rectum and not and not outside it. And that seemed to be a safer way to do it. So the Soave operation, you bring the normal bowel down, again, sewing it just above the sphincter muscles, but leaving what we call a cuff, or a segment of the abnormal muscle. And that is done by many people now, but the Swenson is also done by many people. And the Duhamel operation is a little bit different. And what you do in that operation is leave the front part of the rectum that doesn't have normal nerve cells and bring the normal bowel down behind it and kind of connect these two pieces of bowel so that you end up with a area at the bottom that stores the stool before you can evacuate it. And there are normal nerve cells in this part so that it functions well, but it was also thought to be safer than these two operations, because you really only operating kind of at the back of the rectum. And again, the sphincter muscles are left intact, and we try not to touch those so that they can function. This is the Duhamel operation. There's no evidence anywhere really that any of these three operations is better than any of the others when done by a surgeon who's been trained to do that operation and does that operation frequently. So, we're often asked, which is the best operation? And nobody really knows that, because there probably isn't a significant difference in outcomes. Some of the operations have potential complications that others might not have, but in the big picture, whichever operation your surgeon was trained to do and does frequently and is comfortable with is the right operation for that child. Just going to move this down there. Okay. So a lot of people who come to these webinars, their child has had an operation for total colonic Hirschsprung's disease, or aganglionosis, just means no ganglion cells. Because kids with total colonic Hirschsprung's often have more problems than kids with a shorter segment. So I wanted to just go through the different operations for total colonic Hirschsprung's, because it can be a little bit different. The first option is to just remove the entire colon and bring the ileum, or the small bowel. That's the name. The ileum is the last part, the bottom part of the small bowel. Just to bring the small bowel down and hook it up at the bottom end, just like I showed you before for kids with shorter segment of Hirschsprung's disease. And that can be done using either the Swenson, the Soave, or the Duhamel, except that in this case, this would be small bowel rather than colon. But the potential problem with that is that the colon absorbs water and makes the stool more solid. And so many years ago, surgeons tried to think up other operations where you might leave some of the colon behind to help absorb the water, but still bring the small bowel down to the bottom, because you need those nerve cells to expel the stool. So the first one that was described like that was by Dr. Lester Martin, where what he did was he left the left side of the colon in, removed this pink part, which is the rest of the colon, and then brought the small bowel down and sewed it kind of side to side, all the way down like this. This is really the same as a Duhamel, but it's extended and much longer, leaving a big long patch of colon behind. And the theory was that colon would absorb water, and the small bowel would provide, the small bowel here would provide the propulsion to get the stool out. And then Dr. Kimura, he thought that the left colon was not as good at absorbing water as the right side of the colon is. And that's true. The right colon is much better at absorbing water. So he designed an even more complicated operation where he took out all of the left colon. And remember, this is total colonic Hirschsprung's, so there's no ganglion cells in any of the colon. And he left behind this right colon, and then sewed the small bowel to the side of that and brought that out as an ileostomy, as a starting operation. And the reason he couldn't do it all in one operation is because of these blood vessels that supply blood to this right side of the colon, and they're too short to reach all the way down into the pelvis. So he did that as the first operation. And then the second operation, which was done 6 months later, after this right colon had picked up some blood supply from the small bowel here, then he could divide all these blood vessels and do the pull through in a second stage. Both of these operations, these colon patch operations, work pretty well initially because the colon does absorb water, and the stool gets to be more firm than if you don't have that colon patch. But unfortunately, what happens over many years is that colon patch that doesn't have ganglion cells eventually gets very dilated, and those kids develop a lot of infection, and the stool can't get propelled by that bit of small bowel. So most of the people who had these operations in the past have not done well, and we've had to go back and remove this colon patch. So some of your kids might have had this operation. It's not being done very commonly anymore, but it is something that's worth knowing about. And then the last thing that's sometimes done, mostly in Europe, not so much in North America, is what we call a J-pouch operation, which is what's commonly done for adults or older children with ulcerative colitis, where they have their whole colon taken out as well. But they're much older when they have this. And that operation is basically removing the entire colon and then creating a little pouch out of the small bowel to create a bit more of a reservoir to store the stool, and then sewing or stapling this pouch just above the anal sphincters here. Again, this is done in Europe, particularly in Scandinavia, but in North America, it really is not done very often. Okay, so that's kind of a primer on surgery for Hirschsprung's disease. And now what we're going to do is talk about problems that kids have after their surgery. And there's three categories of these kinds of problems. The first is they may have persistent obstructive symptoms. And when I say that, I mean they can have abdominal distension, they can have severe constipation, they get a lot of gurgling in their abdomen. Sometimes they throw up because they're obstructed. And this is a common problem that we're going to go through in some detail. The second problem is soiling, and the third is enterocolitis. And so I'll talk about persistent obstructive symptoms, and then Dr. Rentea will talk about soiling and enterocolitis. So there are essentially 5 different causes for obstructive symptoms after a pull-through. And the first one is a mechanical obstruction, just a mechanical blockage, and it's usually related to the surgery itself. This is an example of a child who has a very tight stricture. So this is a barium study, and you can see the pull-through is here, and then you can't even see the channel here. It's so tiny. So this is something that happened at the time of the surgery or after the surgery, and it needs another operation to redo the pull-through and fix that. This is a child who had a Duhamel. Remember, in the Duhamel, we leave the patient's own rectum that doesn't have any nerve cells in it, and we bring the normal bowel down behind it. And then normally we use a stapler to connect those two. But in this case, that connection was only short here. And this is the kid's rectum that doesn't have ganglion cells, so it's filled up with stool. And that stool has just kept on building up and building up. And because there's no ganglion cells in this, it can't empty. And it gets so big that it pushes against the normal bowel that's come down here. So this also requires an operation to fix that, either by removing this big native rectum here, or by extending this staple line like it normally would be after a Duhamel. And this is another cause of mechanical obstruction. This you can see it looks like a curly thing here, and that's because the bowel, as it was being pulled down, got twisted, and that obviously causes a kink or obstruction here, and that is another problem, a mechanical obstruction that needs another operation, a redo of that pull through. The second problem that can happen is that the bowel that's pulled down, which we would hope has normal nerve cells in it, and we always check when we do a pull through, we do a biopsy to make sure that that piece of bowel that we're pulling down has normal nerve cells. But sometimes there's an issue with that and we don't get that quite right. And the bowel that we pull down may have either no ganglion cells or it may have ganglion cells, but it might be in that transition area between the normal and the aganglionic, so that the number of ganglion cells may be not adequate. And this is an image that shows these big, huge nerves in the biopsy that suggests that this is kind of in between the normal and aganglionic bowel. And that's what we call a transition zone pull through. And that can happen because the pathologist made a mistake when he was looking or she was looking at the biopsy we send in the middle of the operation. Sometimes the ganglion cells are there and we have good evidence that the bowel we pulled down was normal, but for whatever reason, we don't understand why. Sometimes kids will lose those ganglion cells. Sometimes it's just that we know that the transition zone between the aganglionic and the normal bowel is not even. It's like a paint can. So if you imagine that the white part here has no ganglion cells and the paint is where the ganglion cells are, we could do our biopsy here, like maybe right there, and think, oh, this is normal bowel. But in fact, a lot of the circumference of that bowel is not normal or doesn't have normal ganglion cells. So the transition zone pull through is not a mechanical problem. It's a functional problem because we haven't gone quite high enough on the bowel that we pulled down. And that usually requires a second pull through. And this is what that might look like on a contrast study. This looks just like a child who has Hirschsprung's disease, where the rectum is narrower because it has no ganglion cells, and the bowel that's above it is more dilated because it can't push the stool through. So that's the second cause. The third reason that kids might have obstructive symptoms is because the bowel that we've pulled down that has what look like normal ganglion cells on the biopsies may not function normally. And we know that this happens in some kids with Hirschsprung's, even though under the microscope, it looks like there's normal nerve cells there and everything else looks fine. That bowel does not move the stool along normally. That's what we call motility, which is that peristalsis, or that pushing function of the bowel pushing the stool from one end to the other. And this is an image of a manometry where we put a long catheter throughout the colon and then measure the pressures in the transverse colon and all the way down to the bottom. And we should see these waves of peristalsis, these waves of pushing it down. And so sometimes that's abnormal in kids with Hirschsprung disease. The fourth reason why kids can have obstructive symptoms is because the anal sphincter, the sphincter that we use to control our bowels, has an internal component to it. There's an internal sphincter and an external sphincter. The external sphincter we have control of. We can tighten it or loosen it at will. That's what we use to get to the bathroom so we don't have an accident. The internal sphincter we don't have control over, and it normally relaxes when the rectum gets distended. And that we can measure that. This is anal rectal manometry, where when you blow up a balloon, that's blowing up a balloon in the rectum, you can see the internal sphincter relaxes. And that makes sense because when the rectum gets distended, you want your sphincter to relax so you can evacuate the stool. But kids with Hirschsprung's disease do not have that reflex. When you blow up a balloon in the rectum of a child with Hirschsprung's, the internal sphincter does not relax. Sometimes it even contracts, it gets tighter. So these kids, every single kid with Hirschsprung's is missing that relaxation. And many of them can figure out how to overcome that non-relaxing sphincter. But some of them can't, and that in itself makes them obstructed and makes it harder for them to evacuate. Um, and the treatment for that is used to be to cut the sphincter. It's something we call a myectomy. And that works, that's great, but sometimes that by doing that, that permanently injures the sphincter and can increase the risk of soiling later on. So the way we tend to do it nowadays is by using Botox, which most of you have heard of for wrinkles in your face, but it's also very good for relaxing the anal sphincter in kids with Hirschsprung's disease to help them to evacuate. And then the fifth thing, or the last thing that can cause obstructive symptoms is just stool holding behavior. That's a very common cause for constipation in normal kids. Around the time of toilet training, they will often hold the stool in because they're figuring out how not to use their diapers anymore. And kids with Hirschsprung's disease can develop that habit as well, particularly because they're more likely to be constipated from that non-relaxing sphincter. So they may have a hard stool, which is painful to pass, and their little 2.5-year-old brain says, wow, that really hurt. I'm not going to do that again. So they hold it in and hold it in and hold it in, and then eventually they have to have a stool, which is, again, really hard and painful, and it's a vicious cycle. So a lot of Hirschsprung's kids get into that vicious cycle, and that in itself can be a cause. So now I'll pass it over to Dr. Rentea, who's going to talk a little bit about soiling.
Passing over the garbage can.
Yeah.
So this is a pretty dramatic picture to get started with. We've talked about obstructive or blockage symptoms that can stop poop from coming out and cause trouble with Hirschsprung disease after a pull through. We're now going to switch gears and talk about soiling, which is basically leaking or having poop come out when you don't want it to. And then the last thing that we'll talk about is enterocolitis, both like when it comes on really quickly, acutely, and then when it's kind of recurring and coming back as a theme. So firstly, soiling. So there's a couple different causes of soiling or passing stool when the child is not ready to have poop come out after pull through. The first reason is poor muscle control. And that can be caused by a few different reasons, but the big one is really a stretch injury that occurs at the time of surgery. And so you can imagine when you see poop come out, that's about the amount of actual ability that you have to see in that area. But all pull through surgeries have to have a little bit of a look and a little bit of surgery right at the bottom. So if there's too much stretch in that area, that can weaken that muscle and prevent in the future a really tight squeeze to hold the poop in. Dr. Langer also talked about a sphincterotomy in the past as a way to help poop pass when there was too many obstructive symptoms, but that could potentially have about a 5% chance of actually leading to permanent incontinence. So if there has been an actual cut on the sphincter, this can lead to soiling as well. The next thing after we talked about muscle control is sensation. So how does the child feel that when there is stool sitting right at the bottom of the colon that has been pulled through? Can they feel that that is a signal that means that stool needs to pass? So there can be a very poor sensation in that area and the inability to feel that the rectum is full of stool. This can be tested with anorectal manometry, where a balloon simulates stool size that's increasing. And then this is usually done kind of partially awake or sedated to say, when does that response occur that the squeeze happens to feel that there's actually poop and it needs to come out. Another reason for poor sensation is that there can be a loss of the anal canal. Essentially, the last couple half inch right before the exit to where stool comes out, the anal opening, has some cells that are very sensitive in being able to differentiate liquid versus solid. And there's also the sphincter to close the anal opening right behind that. So if the pull through was done a little bit low, there can be a diminished, kind of proportionally diminished sensation that there is stool coming through. The final reason for soiling is something called pseudo-incontinence. It's basically when really bad constipation, so about 80+% of children that have rectosigmoid transition zone Hirschsprung disease, that's the most common type of amount of aganglionosis in the colon, kind of that last part of the colon, about almost a foot or a little bit under. Those children tend to have constipation as one of the primary struggles as they get into toilet training. And if the constipation really builds up, it can lead to soiling because the liquid stool comes around the large stool ball. So it looks like the child cannot hold it because there's constantly liquid that they can't control, but really it's caused by ineffective clearing of a large poop ball that's causing all the problems. Another reason for pseudo-incontinence is when the opposite actually happens. While we talked about that 80 to 90% of kids can struggle with constipation, there's about 10% that actually have a colon that moves too fast, and that's called hypermotility of the pull through or of the colon. And a lot of, because constipation is such a common problem, and Dr. Langer talked about these really hard stools that can give a really negative pattern to children, that it hurt to pass large stool or that they couldn't even get it out. A lot of physicians start Miralax, which is a softener, so a musher of the poop, or they start Senna, which is a pusher of the poop, such as a stimulant laxative. And when those two are given in the setting of a colon that already moves too fast, it can only make things worse. And depending on if you have somebody who kind of recognizes this or gets a picture, it can be under-recognized for a while until finally all the laxatives are stopped and suddenly the child does not have any more problems with soiling. Another barrier can be struggling with developmental delay in the setting of toilet training. And this can basically prolong trying to get successful toilet training, in addition to all the problems that we talked about, or muscle control, sensation, pseudo-incontinence, kind of making sure that we've ruled out obstructive issues. But if you're struggling with any other problems that have led to difficulty toilet training, it can prolong the situation and make it even more difficult. So what do we do to make the diagnosis? History, essentially talking about what type of symptoms, what type of problems the child is experiencing. An anorectal examination under anesthesia, or an EUA. This is usually done under anesthesia so that we can really get a good look at the anatomy. What are we looking for? Well, we're specifically looking at those areas that we talked about, kind of those first 2 inches right before the anal opening is what we're looking at. So anorectal manometry can help to look at sphincter function. We talked that there's differences in how sedated a child is to get some of that information. So if the child is very sedated, you can get that rare reflex where we talked about the rectoanal inhibitory reflex of just inflating a balloon and getting the sphincter to react to say, what does it look like when it does that, versus sensing fullness, where if the child is able to be a little bit more participatory, you can get just a bit more information. And then finally, importantly, soiling, as we talked about, can be when there's blockage of poop, blockage of the anatomy. And so you also want to make sure that all the causes of obstruction have been evaluated. So we want to treat any causes of obstruction and stool holding, also called stool retention. And if the child is constipated, we work on a toilet training routine, make sure that there's a diet that's very high in fiber. And it's not always the fiber that we talk about that's the water insoluble. That's the one that rushes through you. Those are those, the fiber that they put in the food bars where suddenly you have to go to the toilet. It's really talking about fiber that bulks you up, which is water soluble fiber, but also the fiber in the diet that helps a bowel movement bulk and get out of the body. Adding laxatives to make the stool leave the body and to loosen the stool if it's too hard. Stimulant laxatives are really needed often if the poop can't actually physically exit the body. So that's where you have the Senna and the Dulcolax. If a child holds on to their poop, meaning think back when a child is born and we do irrigations, and I'll talk about that in a minute in some more detail. If we have to do irrigations and the child cannot let the stool out of their body, putting an enema into the colon is not a great idea, because then it can exacerbate stool holding behavior and those retentive behaviors. And then if the child is able to participate and understand, biofeedback training is an option. If stools are loose and frequent, one of the things that we'll talk a little bit more when we get some of the questions is like, what are some of the details that we do for the workup? But a contrast enema often helps to differentiate a lot of these different causes. And those are really the pictures that we saw in Dr. Langer's presentation and in my part, where really that is one of the first roadmaps to see what's going on. And even though you can't see the last little part of the anatomy, and that's where we do the examination under anesthesia, the contrast enema does provide some really great information. And so, for example, it can tell you if the colon is really narrow in size and the child is stooling and is otherwise is doing fine, maybe the colon just moves too fast. So a diet that is low in fiber, we avoid sugars, milk, stuff that really makes the poop move out of the body. We don't want to use laxatives, and we want to do the opposite and slow the bowels down with something like loperamide. Other medical problems after Hirschsprung, so in addition to Hirschsprung's, can exacerbate and make the problem worse, such as eosinophilic colitis. And we can consider things like adding a course of Flagyl, probiotics, and then really making sure that the skin around the area that has that liquid stool that can be extremely irritating is protected. Because the older a child is with toilet training, when they're also struggling with external pain on their perineum, on the basically the private parts, that can really make the toilet not an option if you're already struggling with a child who's hurting. So if there is true incontinence, meaning that there is no control at the bottom, sometimes diet and loperamide do work, meaning slowing the stools down and making it a controlled sensation such that the child can feel the stool coming through. And then other management options do exist, meaning can we get to that time where we have a child that does get into normal underwear and make doing other activities possible? And the answer is yes. So that includes the need for bowel management. And those are options such as enema to clear the last part of the bowel, or something called an antegrade or MACE or cecostomy. So that's where the fluid that normally would go into an enema just in the bottom goes instead to the top part of the colon and then comes out of the bottom while the child sits on the toilet. Depending on the workup, the discussion, etc., there could be a need for a temporary or a permanent colostomy. Lastly, we'll get to the topic of Hirschsprung's associated enterocolitis, or HAEC. So this is one of the most important things that we talk about. And it's where essentially the child gets a fever, a poochy tummy, a distended tummy. They can have diarrhea, really foul smelling stool, and they can get extremely ill. And an important conversation once the diagnosis has been made around this constellation of symptoms is really key. And it's basically caused before surgery by blockage of the inability for stool to come out, for waste to eliminate. But after surgery, enterocolitis can still exist. So it's basically pressure building up of unevacuated gas and some stool, leading to abnormal proliferation, more gas. And we don't know why somebody who's never had surgery can have 2 weeks of not going to the bathroom and be fine. And a child within 24 hours, if they have a history of Hirschsprung's, can get basically extremely sick. So in the acute setting, treatment involves an irrigation. It's like the 1 through 10 version of treatment. A nasogastric tube, so a tube in the nose to get out all the fluid if there's tons of vomiting. IV antibiotics and IV fluids. If enterocolitis keeps coming back, there are treatments and strategies to prevent recurrent enterocolitis, but I would put a huge asterisk here that this is done in coordination with the surgeon, considering in the background any of those other topics that we just covered. So if all of those things have checked out and we're not dealing with those, then it's making sure that we irrigate frequently and when needed, when some of those symptoms of really bad stool or abdominal bloating occur, we're kind of regularly doing irrigations to wash the colon. Long doses of flagyl or metronidazole. Potentially trying probiotics. Some children it really works well in, others not so much. Giving Botox injections so that there's not a blockage at the anal canal so that stool can exit freely. And then at a, again, kind of if everything checks out and the episodes are quite severe or in the setting of acute enterocolitis, stool can't be irrigated out, an ostomy. REACH overall has, I think, had an extent beyond our group here today in that there's a Hirschsprung's alert card that has been placed online. And I just kind of put some of the wording on this slide and kind of carrying this alert card around. And can you go to the next slide? I think really what we've highlighted here and what REACH has done to put together this beautiful passport that is available to everybody in the community is to alert other physicians such that when a medical crisis is happening, a parent can hand the card that says when the surgery happened, if enterocolitis has happened, so that any provider can communicate with another provider about Hirschsprung's enterocolitis and what type of management needs to occur as some first steps. The cause can be unclear. And enterocolitis can occur more frequently with long segment disease and trisomy 21. It really is, it's been recognized for a while, but it really is one of the most extreme and sad cases of early mortality and morbidity, meaning a child can actually pass from enterocolitis. And so a really, really detailed, clear conversation, understanding of moves that families can do at home, such as irrigation, how to call, who to call, is really of the most extreme importance.
Okay, so I'll just kind of summarize everything that we've talked about very briefly, and then we'll have time for questions. So, there we go. So most kids, I mean, we've spent the last 40 minutes talking about all of the bad things that can happen after a pull-through, but it is really important to remember that most kids with Hirschsprung's do very well after surgery. And most of the problems that we've talked about improve over time, either because we figure out the cause and we deal with it. For example, if the pull-through has to be redone, then we deal with that. But even things that we can't fix with an operation, like the non-relaxation of the anal sphincter, enterocolitis, even soiling, most of those problems over time, if you follow kids out with Hirschsprung's out until their teenage years or their 20s and 30s, most of those problems get better over time. And this is with permission from this family. This is a baby with Hirschsprung's that I operated on many years ago. You can see his big distended tummy. This is him after his pull-through. He's about a year old, and that's after the pull-through. He still has a distended tummy. This is a baby who continued to have ongoing issues with obstructive symptoms even after the pull-through. This is him around 3 years of age, and he looks very happy, but he was still having intermittent problems. He was having soiling. He didn't really get toilet trained until he was 4 or 5 years of age. And this is his mom and him about a year ago. He's now about 23 or so, and he is a completely healthy, functional guy who is making trouble in the world like he's supposed to at that age. So, and this is the common story that that I find. Even though kids can have pretty significant problems in the first few years, usually by around 5 years of age, they start to get better, and by the time they're this boy's age, most of them are doing very well. And then the other take-home message is that effective management of these kinds of problems, these problems with obstructive symptoms, with soiling, and with enterocolitis, the management or the treatment of them has to be based on a clear understanding of what the underlying problem is. And unfortunately, many people out there don't really have an appreciation of how to approach these problems. So one of the things we've spent time on the last few years in the American Pediatric Surgical Association, APSA, which is called APSA, the Hirschsprung's disease interest group. So there's a group of surgeons who have a particular interest in Hirschsprung's. We've come up with algorithms for obstructive symptoms, and this is the one for obstructive symptoms and for soiling, and also for enterocolitis, but I didn't put that on here. And these are designed for surgeons, gastroenterologists, pediatricians, anybody who's taking care of kids with Hirschsprung's, so that they can really understand all of the stuff we just went through. What are the specific different causes, and how do you work the child up? What tests are appropriate? How do you interpret those tests? And then what do you do about it once you've figured out what the problem is? These are published, and anybody who's interested in sharing them with their doctors, they should let us know, and we're happy to give you the references. Okay, I think it's time for questions. I love this slide because it really is perfect for Hirschsprung's disease.
Excellent. Well, thank you so much, Dr. Langer and Dr. Rentea. We have questions that were sent in prior, but I will encourage any of those who are with us today to absolutely put your hand up, and we'll get to you also. So while you're thinking of your questions at home, I will start with one from Amy. She is asking, currently my 3.5-year-old is potty trained. He has short segment HD, had to pull through around 1 week old, and lost 25% of his intestines, rectosigmoid. He's had numerous Botox procedures, which have helped most of the time. We currently give him a suppository every morning before his day starts to clear him out. He also gets Benefiber. My question is long-term use of suppositories harmful in any way? And if we think he's also withholding, will suppositories address this behavior?
Well, I'll take that. So he's 2.5 or 3.5?
He's 3.5.
3.5. Okay. So I mean, this is a very common scenario, like we talked about. It sounds like if Botox is working for him, it sounds like his main problem is probably that non-relaxing sphincter, because Botox relaxes that. And if you get improvement, Botox is not only a treatment, it's almost the diagnostic test too. If the child does well with the Botox, then it suggests that the sphincter is the main problem. And the problem with Botox, of course, is that it wears off after 3 or 4 months. And that's why kids may need repeated injections of Botox. So first, I would say that most of the kids like this, as they get older, they need the Botox less and less frequently. And most of them by 4 or 5 years of age stop needing the Botox. And that problem does almost always get better by itself, which is why we started using Botox instead of cutting the sphincter, which is what we did up to maybe 20 years ago. That was the standard treatment, and it worked great. Cutting the sphincter worked really well, but then it's a temporary problem, and it was being treated with a permanent solution, which is cutting the sphincter, and that cutting of the sphincter can cause incontinence and soiling. So I would be very positive about the chances. Now, whether the question was whether using suppositories, or I would add using irrigations or using stimulant laxatives, whether any of those things cause problems if you use them long term. And the answer is no. There is no evidence that using suppositories or irrigations or enemas or using stimulant laxatives like Senna cause any problems in the long term. And there is a public misconception, especially amongst pharmacists for some reason, that using these things, and especially using Senna, long-term is very harmful to the bowel. But we have pretty good evidence in children with Hirschsprung's, with anorectal malformations, that you can use senna for many years and it does not cause any problems. It doesn't cause a lazy bowel, which is what most people think. That just simply isn't true. And Dr. Rentea, I'm sure, will agree that we use these things very, very commonly in this population of kids. And we've got lots of.
And what's a little bit different also is in a lot of the literature, people kind of just start something really, really small, whereas a lot of the work that we do when we see the children often is that it's actually weight-based dosing. So the pharmacist will always come back and say, wow, that's a big dose, but it's like, that's the dose that actually gets the poop out. So it's more results-based.
Thank you. Okay, the next question that I have here is from another mom who said her child was suspected of having Hirschsprung's. They said that it looks like a classic case based on x-rays and GI study, but when they went for the biopsy came back negative. They now want her to see another pediatric surgeon. They still suspect that it could be Hirschsprung's. She's wondering what the possibility of a false negative biopsy would be in a newborn baby if that happens, or is at the meantime she's continuing to treat. They're still treating with irrigations, etc., as though the child were HD.
Mm-hmm. So that's it sounds like they're in good hands, meaning that if there's symptoms that seem like they're blocking the bowel, managing that, I think, as a first step to actually get the child more comfortable and get the stool out is really key. Specifically about the pathology. So when we look, depending on the child's age, at the biopsy specimen or when the pathologist looks at it, they're looking for two things. One is ganglion cells, the presence or absence. If you don't have them, that's more indicative of Hirschsprung's, but also the size of the nerves. So if the first specimen was too low or was inconclusive or not enough of the layers were obtained during that biopsy, that could result in needing to repeat it. So I think that was really something to consider, is what is being looked at, and then where, like it's about a quarter to a half of an inch of geography difference that can really change if this is Hirschsprung's versus not. I think one last thing to add is, depending on if there's a GI team that does anorectal manometry and how comfortable they are, that can really be helpful and additive to finding that diagnosis, because a good GI doctor can find on anorectal manometry if that reflex is present or not. So they can say if there is a rare present, that means that it's normal, versus if there's not that reflex there, that could be internal sphincter achalasia. That could tell you, yes, you need to do your biopsy, like go for it, because that is likely that you have to rule out now Hirschsprung disease.
Yeah, and how old is the child? I don't think we heard.
They specified a newborn.
A newborn, yeah. So in a newborn, the rectal biopsy is going to be done in most cases using a suction biopsy technique, which is a bit blind. It's done at the bedside. It's a great technique because it doesn't require anesthesia. It's done at the bedside, but you put the probe in that takes the biopsy, and you really can't see exactly where you're taking the biopsy from.
Right.
And I have seen cases where the biopsy was done a little higher than the person thought it was done. And the child had Hirschsprung's disease, but just involving a relatively short distance of the rectum. So in general, I agree with everything Dr. Rentea said. And in general, if the child continues to act like they have Hirschsprung's and they've had a suction biopsy like that, I would usually repeat the biopsy. There's very little risk to doing that. I have seen cases where the next biopsy actually shows Hirschsprung.
Okay, and you were right. It does say a suction biopsy. Note that.
Yeah.
Okay, I see we have some in the chat there, so I'll let Raina. There we go. Can everybody see this, or do I have to read this out? Can you see this, Dr. Langer?
I cannot, but let me check the chat. No.
Here, I'll read it, but Dr. Langer, this one's for you. Children with the rare form of TIA who have a small amount of ganglion cells in their stomach, is there stem cell research being done in terms of migrating ganglion cells to the small intestine to allow for future pull-through surgeries?
Yeah, so when you say TIA, it's a total intestinal aganglionosis. So what we're talking about is the most severe form of Hirschsprung's disease, where everything is missing ganglion cells, except for, in this case, the stomach. Occasionally we see even the stomach is missing ganglion cells. The most common total intestinal Hirschsprung's is near total intestinal. So most of the kids with that severe form actually do have 15 centimeters of small bowel that's involved. But if there's no ganglion cells anywhere in the small bowel, right up to the stomach, then the only thing really that can be offered to that child is TPN, is total intravenous nutrition, and small bowel transplantation at some point down the road. The idea of repopulating the small bowel and or the colon with ganglion cells is it is an excellent idea, and there's very good research being done to figure out how to do that. But we are at least 10, I'm going to say 10 years away from that being possible. And the problem with it is that the kids who would need it the most are the ones with total intestinal Hirschsprung's, but they're the most challenging to repopulate. You know, if you had a short segment, it would be easier to try and put ganglion cells into a shorter segment, but those ones don't need it because we have surgery that fixes them. So at this point in time, even though there's promising research, we are still a very long way away from that.
And there's a second question there. I don't know, Dr. Rentea, if this is a you or a Jack thing. I'll let you two decide.
We're playing ping pong, so it's her turn.
Playing ping pong. I'll read it and answer this one. So is it common or expected for Hirschsprung disease children to have long-term flagyl use? Are there concerns with this? My 5-year-old son has had short segment Hirschsprung disease pull through at 10 days of life, has been on and off flagyl for 3 years due to symptoms leading to enterocolitis. He continues to be on Senna as well and has had a round of Botox at age 2. He has never had a contrast study or anal manometry done. So this is basically kind of right in the topic here that we're in. So one of the first things really is, how are we emptying the stool? And depending on what practice and who you kind of talk to, I think one of the first steps is really saying, is the stool actually getting out of the body? And so is this flagyl with irrigations, flagyl without irrigations? And then I think, Hirschsprung disease is pretty humbling. And at some point you kind of have to sit back and just say, okay, we have to start from square one. So that is all of those things that are in the comments here. A contrast study, kind of evaluating how did things heal? Can the poop get out well? Is there any other reason why the poop can't fully get out and kind of causes repeated enterocolitis? Long-term flagyl use, Dr. Langer, what's your thoughts on that?
I'm actually very liberal about using flagyl for kids who have intermittent or kind of low-grade enterocolitis, and I have used it for years, especially in total colonic Hirschsprung's, where I find even after the age of 5, some of the kids do still keep coming back with these kind of bloating, obstructive symptoms, maybe low-grade enterocolitis. So I'm pretty liberal about its use. However, I think it's important to go back to the last slide that we showed in the summary, which is you need to understand the basis of the problem in order to figure out what the right way to deal with it is. And it's possible that there is some other underlying problem that hasn't been figured out that could be fixed and avoid these enterocolitis episodes and the need for long-term flagyl. So I would go back to that algorithm that I kind of flashed to you, but really what it does is go through the 5 causes of obstructive symptoms. And enterocolitis is really related to obstructive symptoms because the underlying problem is that the stool doesn't get out enough, as that slide that Dr. Rentea showed, where there's some delay in emptying and the bacteria start getting overgrown in the stool, and that leads to enterocolitis. So I think a contrast study is really important. You need to make sure there's no obstructive problem there, no mechanical obstruction. This is a child who I would do a repeat rectal biopsy to make sure that the ganglion cells are normal, that it's not a transition zone pull-through, because certainly transition zone pull-throughs can result in these kinds of symptoms and ongoing enterocolitis. So I would go through that whole algorithm and make sure that there's no underlying problem. Now, there are some kids who just are really prone to enterocolitis, and in those kids, I think giving them flagyl long-term is not a bad thing. But I'm not sure that I don't think that this child's been investigated.
Yeah. Gonna start back at the top.
I figured out how to see the Q&A.
There you go.
Yeah, it was really hard. There's a little button at the bottom that says Q&A.
So we have a third question there from Elise.
Okay. So it's my son is almost 4 and is in a similar situation as Amy's son, which was
the child we spoke about first, the 3.5-year-old,
right, who had Botox, sphincter issues with holding issues. Yeah. He was 4-year-old, was recently potty trained, and through doing a suppository, I noticed that one part of my gloved finger goes into his rectum. Once my gloved finger goes into his rectum, he's able to start pushing out the stool on his own, but isn't able to without help. What are some strategies that will help him initiate on his own? Curious how other parents have handled withholding behavior. So what you're describing is actually pretty typical of the non-relaxing anal sphincter. When Dr. Rentea talked about the RAIR, that's actually spelled RAIR, which stands for rectoanal inhibitory reflex. And that's the normal reflex we talked about, where you stretch the rectum and the sphincter relaxes as a reflex, which kids with Hirschsprung's don't have. So it's very typical for a child with Hirschsprung's to have trouble evacuating. And if somebody puts a finger in their rectum, it causes it kind of stretches the sphincter a little bit and allows that stool to come out. So kids like that, if they're younger, I mean, 4 years old, he's a little bit old for this, but in younger kids, you can do rectal stimulation. So every time, a couple times a day, or when he looks like he needs to go, then you just put your finger in there, or you can put a dilator in there, or in a baby, you can put a thermometer in there, or whatever. In a 4-year-old, that's probably not feasible. Botox may be helpful for this child. There's also topical ointments that you can put on the sphincter, kind of just put it right up as high as you can easily go. And it's called nifedipine ointment, which is also a dilator or a relaxer of the anal sphincter. And I've seen some kids where that's been helpful. Unfortunately, most of them, it doesn't seem to work, and it may be just because they can't get it close enough to the sphincter. But it's something that's worth trying because it's very easy to do and doesn't require the general anesthetic that a Botox injection requires.
I think this is like a really tough, 4 years old. I think this is one of those ages where you kind of go from needing irrigations to kind of learning to use your abdominals, push, and then use that ability basically to kind of understand what it's like to relax your sphincter. And so what has worked for some of my families is putting the Botox in and then having the child kind of learn what it's like to either blow on a windmill or something, where they engage, like they put their little feet on a potty stool, like on a little elevated chair, and to kind of actually practice, okay, what can I do to help get the poop out? So that again assumes that you've gone through, excluding like actual blockages and other issues, but there is like that kind of time where it's like a lot of work to get the actual toilet training happening, but there will be an ability.
Yeah. And biofeedback, Dr. Rentea mentioned biofeedback, but that can also be helpful in this situation. And the way our people do it is they actually do the manometry and have the child squeeze and relax their external sphincter that they have control of while they're watching on the screen. So they get to know their body, they get to understand what's happening when they're trying to poop. And once they get old enough, then they can kind of learn how to do it better. And pelvic floor physiotherapy is another thing that's related to that. Can sometimes be very helpful. I guess the last thing I would say is that that this problem does get better over time. And he's 4 years old, but I think this is a problem that will not last indefinitely. We'll figure it out.
Great. Okay, so this question I know comes up quite a bit at our symposium. This mom has a 5-year-old son with total colonic Hirschsprung. He seems to be doing okay right now, but one thing he seems to not be able to get control over is the rash that he has, and it actually becomes quite bothersome. Is there anything, and it just seems to never completely heal, she said, is there anything special or specific that she could do to help treat this matter?
All right. So I think this is, kind of another one of our challenging problems. So this goes kind of back to that hypermotility where the bowel is actually moving. We don't have the colon, so you're not really getting constipated stools. There's no water absorption. And the stool is kind of coming out all the time. And that liquid stool really is just extremely caustic and burns the butt cheeks. And so it's twofold. One is making sure that the poop can actually get out. So if the child holds onto the poop all day and all that comes out is a little bit of liquid drips, that can also just, be a total problem. The other thing is a quick evaluation to make sure that there is continence, meaning can the child actually hold the stool and it's not just kind of coming out all the time. So then now the target is top end and bottom end. The top end is thickening up the poop, slowing the poop down, and then also working, depending on the age of the child, on toilet training. So if you're at toilet training age, it's setting that expectation that there's going to be more frequent stools. So like 4, 5, 6 times a day, there's going to be a continent stool where you sit on the toilet and go. If you're a baby, different. And then, so that's like through water soluble fiber, Imodium, etc. On the actual skin end, that is a lot of dedication with woundostomy care. I personally am an advocate for either Cavalon Advanced or Marathon. That's like a skin, kind of like basically a skin glue. Really crusting various ointments with stoma powder so that it kind of forms like almost like a topography map around the area, so it protects the skin. You don't wipe the skin clean every time. Danborough soaks, basically that is one where I've learned, I feel like, the most from other families that have gone through this who've taught me, but basically you do everything, all of those things, and you just try to create this layer where you control what's coming out and you control the bottom area.
I guess my question would be, is he toilet trained or not? Because I don't know if that's in there, but as Dr. Rentea suggested, most kids with total colonic Hirschsprungs who become toilet trained, that skin problem goes away because there isn't stool sitting on their skin. So if he's not toilet trained, then the next step is toilet training. And in the meantime, the barrier creams are really important, slowing down the stools, it's like everything Dr. Rentea said. Important. If he is toilet trained and he's still having this kind of problem, then the chances are that there is leakage of small amounts of stool. And then you have to go to that soiling algorithm, and anorectal manometry would be important to make sure that the sphincter muscles are strong enough and that the sensation is adequate. And then, your strategy will depend a little bit on what you find. There are a couple other things that I have found helpful. One is that flagell, we talked a lot about flagell, but sometimes the skin irritation, I think, is related to kind of a low-grade enterocolitis, an inflammatory process that's going on. And so I have found in some kids, giving them flagell, it slows things down, it decreases the number of stools, and it helps with the irritation on the skin. And I don't have a good explanation for exactly how that works, but I'd rather have something work and not understand why than it not work. The other thing is cholestyramine, which binds bile salts. And sometimes the thing that's most irritating in the small bowel contents to the skin is the bile salts. So giving cholestyramine sometimes helps. And you can also not only take it by mouth, but you can also put it into the slurry of stuff that you put on the skin, and that can sometimes be really helpful.
Great. I think we have a few more questions here in the chat, so we'll, anonymous attendee, here you go.
I'll read it. My daughter is now 3-year-old. She had a pull through when she was 5 months old, but had an infection, so she ended up with an ileostomy. Then she underwent a redo pull through, but after surgery, they found scar tissue around her intestines. Right now, she still has an ileostomy. Is scar tissue common after a pull through, and what would be the best treatment for this?
Well, so there's different kinds of scar tissues. The first thing is anybody who has any kind of abdominal operation, whether it's for Hirschsprung's or any other reason, can develop what we call adhesions, which is scar tissues inside the abdomen. And most of the time that scar tissue doesn't cause any problems, but in a small percentage of people, it can act like a rubber band, or it can kink intestine and cause a blockage, a bowel obstruction later on. And that can happen anytime, from early after the surgery that you had in your abdomen to 80 years later. So I'm not sure if that's what you're talking about, or if you're talking about scar tissue directly related to the pull-through itself in the pelvis. And that is also a common thing after a pull-through, especially if there's been a problem with the pull-through, particularly if there's been a leak at the time of the pull-through. Then you get infection around pull-through right down near the bottom. And that can cause significant scar tissue, which will make the redo pull-through much more difficult. So, and that's one of the causes of mechanical obstruction that I mentioned at the very beginning. And there's different ways of dealing with that. And I have seen, I've been doing this for a long, long time, but I still from time to time see people who have so much scar tissue around their pull-through from these kinds of complications that there really isn't anything that we can do surgically to fix that problem. But you really, in this particular case, we would need to know a lot more detail before we could give you a real answer.
Okay. I'm just going to jump in with some of our other questions here. We have a lot of questions. We may even run out of time, but we will, I will tell the group this, what we don't get to today, I will forward off to our doctors, and maybe they can quickly email it back, and we will post it on our social media, so everybody feels like they're getting their answers. I know we have one in the chat, but I just wanted to slide this one in because it's a little bit unusual, but this mom has a child who is starting school, and one thing that happened at school this year, her Hirschsprung's child was identified as having ADHD. She's wondering, is there any link to any kind of concentration issues or ADHD or any kind of learning disabilities with Hirschsprung's that she should be exploring? This child is kindergarten, so she's not sure if this is just being a kindergarten child or if there's any link. So.
I mean, I'll offer some thoughts. So short answer is no, but what we don't have a full description of is kind of the neonatal course. Is there anything else that contributed within the critical care management, basically prematurity, et cetera? The other thing that can really contribute is if there's any discomfort with stooling, feeling comfortable to go to the bathroom, that can kind of make things worse. And then I would advocate very strongly for an actual evaluation by somebody who might, so we have I work with a dedicated psychologist who is familiar with anorectal malformation, Hirschsprung's cloaca, as her concentration. So she not only knows what to look for developmentally, but then also how some of these problems can contribute and make the environment more difficult.
Great. Okay, thank you. And then there's one other that I wanted to slide in, and then we're going to get to the chat. Baby girl had pull-through surgery when she was first born. She's now 3 months old. She isn't pooping on her own at all unless we do dilations. She's strictly breastfed. When she does go, it scares her, and it's pretty sporadic. I called the surgeons to see if it's okay, and they said it's fine. Her poop is dark green and really smelly. We've had a few hospital stays from dehydration and her stomach being distended. And I just want to know, is this normal, or should we be concerned about Hirschsprung's enterocolitis?
I mean, part of that description does sound like that there may be some enterocolitis, the foul-smelling stools, for example, um, and the fact that the baby gets distended. Um, so this could be enterocolitis. Certainly, it sounds like the baby's got obstructive symptoms. But at 3 months of age, it's it's quite possible that this, quite likely, I would even say that this is going to get better on its own. And I wouldn't do anything too aggressive at this point. But the one thing I would do is make sure the mom knows how to do irrigations. And she's doing dilatations now. And I'm assuming that just means like rectal stimulations rather than an actual stricture that she's dilating. But I would say that she needs to know how to do irrigations in case the baby gets sick. And I would probably give it time at this point and, give it another 3 to 6 months before really doing any kind of significant investigation. Okay. Rebecca, what do you think?
Yeah, I think this speaks to being able to get the stool out. And I know that there's like a lot of research that's focusing also on early Botox. So is there something, if you're not going to stimulate and like kind of help the stool get out, if you're not going to irrigate and passively allow the stool to come out, will an injection of Botox to kind of just temporarily relax the anal sphincter, will that help?
Right. Okay, great. And so I think there's one in their chat. Can everybody see that? My son?
Yeah, I see it. My son, 3.5 years old, has had 2 Botox treatments since last summer. The first treatment worked well. The second was 1.5 months post-Botox before he started having good full evacuations. He's struggling now to empty again. With flagell irrigations and PEG Senna, we got things moving, but he's having to really push hard and his movements are skinny little pencil size. We have to fly to Vancouver for his Botox, and with COVID, we are nervous of traveling. We are weighing the risks and benefits of managing at home versus traveling. Is the benefit of him getting the Botox to make things move easier preferred? Rebecca, you want to?
So tell me again, so Botox has helped?
Botox, yeah. So the first treatment worked well. The second, it sounds like it was 1.5 months after the Botox before he had started having good full evacuations, but now he's back to struggling again. He's 3.5 and he's pushing, he has to push hard and the stools are kind of skinny.
Yeah, so definitely when the stools start to get kind of skinny, but the child is trying to push, that tells me that there's a lot of good things happening. Let's assume that all the evaluations check out and that there's not an underlying issue. I would recommend Botox again, but then at the same time also make sure that irrigation supplies, etc., are provided at home, because as we talked about in some other cases, even sometimes a little bit of stimulation to the area can actually help the child start to stool, and that can, along with Botox, can kind of help get you through those months to get a better stooling pattern going.
Yeah, I think I would agree. I think it sounds like if Botox worked before, it will likely work again, and I think it would be helpful. The risk of COVID, maybe we can just address that because that's on everybody's mind. I think at a major children's hospital, the risk of acquiring COVID, going for a day surgery procedure is quite remote. Mm-hmm. There's every child, at least at our hospital, I think it's true at BC Children's and everywhere else, that every child who's having surgery gets screened for COVID, and everybody's wearing PPE. And there's only one parent allowed, so they're limiting the number of people that come into the hospital. So I think, whenever you make a decision like that, whenever you make any decision in life, including like crossing the street, you're doing a risk-benefit analysis. And so you have to, there is a risk of COVID, sure, but it's a pretty low one. And what's the risk to your child of not going and getting the Botox? That's probably a higher risk to him than the risk of COVID.
Right. Yeah, what Dr. Langer said, we've not had any cases of new transmissions within the hospital. It was children that came in that incidentally had it as part of, getting their appendix out the next day that then were tested for COVID. But there's been no cases of employees giving it to children. So you know, I think kind of wearing the mask or two, depending on what new stuff is out there, and the eyewear, I think has, you know, decreased the transmission.
Right. And I just want to jump back quickly because this question comes up a lot in regards to Botox, since we're talking about it so much. Parents will often ask, how often can their child get Botox? Because some will say, my child had Botox at 4 months. By 8 months, it seemed to be that, you know, we need to go back again. Some will say after 2 months, it was felt like it could have been done again. Some will say, and then so there's a lot of back and forth. And especially lately, there was a parent where they said, well, the physician said that they just did it 2 months ago. They don't want to do it again, but it really helped for those 2 months. So is there a phase or a period of time that is recommended or not recommended for whatever reason where a child can have Botox?
I mean, so Botox, we know just from plastic surgery, lasts about 3 months.
Mhm.
And I would say that the effects are probably, like, if they're on, if it's actually working, are at least on for 2 months. But there was a systematic review where they looked at all the articles of kids that had obstructive symptoms with Hirschsprungs that got Botox, and they actually found that the positive effects lasted for 6 months. So I think insurance wise, sometimes they just, like, the companies just don't cover it faster because they're like, well, technically, if some Botox is in there, you just can't get it sooner than 2 months. So I personally say if it works, we kind of, no matter what, we have to wait about 2 months, and that would be the soonest that I would redose. Dr. Langer?
Yeah, I mean, I've been using Botox for 25 years now. And number one, I've never seen a complication from using Botox. Number two, it doesn't always work. And when it doesn't work, there's two possible reasons. One is that the non-relaxing sphincter isn't the main problem. You know, we went through 5 different potential causes for obstructive symptoms, and only one of them was really treatable by Botox. So, you know, for example, child might have a mechanical problem, a pathology problem of ganglion cells. It could be stool holding. It could be a motility problem. And if the main problem is one of those things, then the Botox isn't going to work. But the other thing is that there may be that particular lot of Botox, there's something wrong with it. Or it may be that whoever gave the Botox didn't give it in exactly the right spot, and therefore it didn't work, didn't get to the muscle it was supposed to get to. So I will sometimes repeat the Botox earlier than that if the situation seems like Botox should. So I'll sometimes just go ahead and give a different lot of Botox. Also, some people, it has been described that some people develop antibodies to Botox, and so it stops working after a few sessions of giving it. And there are other kinds of botulinum toxin that have been used by some people in that situation. So there are a number. I mean, it's not a simple question. You know, how often can you give Botox? And even when it works, you know, sometimes it works great the first time, and then it doesn't work again. Or sometimes it works for 3 months, and then the next time it works for 6 months, and then the time after that it doesn't work. And I think what that just tells us is that this is a much more complicated scenario than just simply does Botox work or doesn't it work.
Right.
There's so many other things going on, including growth and development of the child,
Right.
as time goes on.
From adding to the chat here, jumping on the Botox talk, does the dose need to be increased each time the child gets Botox? For me, no. I use a pretty high dose, and I use the whole, because it's a single vial. So I use the whole thing and just make sure not to put it anywhere that could lead to issues.
Right.
Yeah, and I'm the same. When I started using Botox way back in the 90s, we started with a much smaller dose. We started with 15 units because that's what was being used for esophageal achalasia. And that's what we kind of thought, okay, we'll just try and do that. And a lot of times it didn't work, and so I would try a higher dose the next time. And because we've never seen a complication from it, I just use the full vial, which is 100 units, except for a very small child. But frankly, I going back to the 3-month-old we talked about before, I know Dr. Rentea said, well, maybe you could try Botox, but because those kids are so easily irrigated, and they often get better on their own, I've generally not given Botox until kids are a year or so of age. And at that point, they give them a full 100.
Right. Okay. Do we have another one in the Q&A? I'm not sure.
Oh, it looks like
Looks
it. Yeah.
like it. Yeah.
Got Ashley.
Ashley, okay. My 2-year-old son, who had a pull-through at 16 days, removing 10 centimeters, had 3 rounds of Botox in his first year, no complications since. He bears down to stool, but his stool is a mashed potato consistency. We're hopeful that he's just learning how to use his muscles for emptying, but I worry this is a sphincter issue. Is there a situation where consistency of stool would cause Botox to be contraindicated? Or would the main focus be determining if it's a mechanical issue, as mentioned? So it sounds like he's actually doing pretty well, except that he has to strain to stool. He may be straining to stool because his sphincter muscle is not relaxing, which we've talked about already. But I would tend, if a child has mashed potatoes consistency stool and is emptying adequately and not having any problems with the toilet training process, and this child's only 2, so I never rush toilet training in a Hirschsprung's child. I would tend not to do anything, I don't think. And I would just give him some time. The specific question of consistency of stool being a contraindication to Botox, I'd say no. When we first started using it, we were worried that maybe the kids would have a lot more soiling after the Botox injection. And I have seen occasional kids where they have a little bit of soiling for a very short time, like a week. But I have not seen anybody who's had ongoing soiling after Botox as a complication of the Botox.
Yeah.
Anything else to add?
I think, one of the interesting things to add to what Dr. Langer says is I view it almost as in like a 3, 4, 5-year-old, when the Botox acts, it allows you to work on the bowels with the medicine. So if you're dealing with both the obstructive symptoms from the sphincter and you're trying to help the bowels move poop out, then you're dealing with 2 things. And it's much less dramatic than you would expect if you're like, well, we're paralyzing those muscles temporarily.
Okay. And one thing I think it might be just a quick thing to address is because we get so many of these questions, is parents often get very concerned about the consistency of stool, the color of stool. Is this normal? Is that normal? And just from, working with you guys over the last 8 years, I've come to understand personally that quite often that's not really much of a thing we get worked up about. Then maybe you might want to quickly address that, just from that sort of what is normal perspective.
Well, I think there's a wide range of normal, and there's a wide range of normal starting from the day a baby is born. We sometimes get very concerned parents who are breastfeeding their baby and the baby's pooping once a week, and they're really worried about that. But if the baby's thriving and doing well, then once a week can be normal for a breastfed baby. Or another breastfed baby might be pooping every time he's fed. So there's a huge range of normal, and that continues as kids get older. So I'm much more concerned about whether the child is having abdominal distension, vomiting, obstructive symptoms, and I'm concerned about the child's growth and development. Blood in the stools. Okay, so red stools, I might be more concerned about, but if they're green or they're brown, doesn't matter. If they're mushy or they're solid, doesn't matter, as long as the child is able to evacuate completely.
Right. Great, thank you. I think it's important to say that because I have to say it's probably the number one thing that I don't send you emails about, Dr. Langer, people's concern over, just the various consistency of stool. And on that note, we have had so many questions, and I know we only have a couple more minutes, so I'm just going to ask one more question. A parent here has a newborn who's scheduled to go for a pull-through, wondering how long after the pull-through is done does it take for a child to pass gas or poop?
So I'll take that question. It can be about 24 hours, but I would say up to 3-4 days after surgery is normal. Often because there's this transanal part of the surgery, there is like some stool that's kind of, because you're bringing stool right down to that area, there's something there. So I think it's almost more that I talk to families about being patient despite seeing stool, because I want to give it 24 hours at least to make sure that the rest of the tummy, the rest of the bowels have calmed down and are moving poop out of the body so that there's not an ileus. That's where basically the bowels are open, but they're not moving things through, so the tummy looks poochy. So I always kind of caution, you may see poop, you may see gas, that's great, but let's give it like a couple extra minutes from the time of surgery to make sure everything else is working too.
Great. Okay. Super. Well, with that, I just want to say on behalf of REACH, thank you so much, Dr. Rentea, for spending this last hour and a half with us and sharing your knowledge. I know I speak for the board as well as all the families in the community that it is so greatly appreciated. And of course, Dr. Jack Langer, who, you know, he's our guy and our go-to. So thank you. And Nicole over there in Denver, just always with us, and always from the mom perspective, she's always great. And I will be sending you some questions, Nicole, because there were some things about kids starting school with colostomy bags and that kind of social aspects. So again, thank you everyone for joining us today. And we will be posting this later on today. So for those who couldn't be here, they can still catch it later.
Pleasure. Stay safe, everybody.
Thank you so much.
Thank you.